This is a meeting of the DCS Community Advisory Committee. My name is Peter Gentala. I'm the chairman of the committee. I'm a senior legal counsel with the National Center on Sexual Exploitation. And we're going to do a real quick roll call. We'll do that instead of introductions, just in the interest of time. But I want to preserve for the record that we do have an active quorum of the committee. So I'm just going to run through, and members, if you just indicate whether you're present or not. Alicia Manuel. I thought I heard Alicia earlier. All right, we'll keep moving. Robin Pearson. Can anybody hear me?
This is Debbie. I can hear you.
I can hear.
Yes.
Okay.
I can hear, but I can't hear you reading off any names.
Okay. All right. We'll do a different approach for Felix and I together. We'll cobble together the roster and make sure that we have everybody here. But if we go through and do name by name, I think we'll have even more challenges. Is the sound okay on my end? Can everyone hear everything that I'm saying? I want to make sure that the meeting can run.
Yes.
Great, thank you.
Yes, we can hear you.
All right. Thanks, everybody. So we'll move from one more thing when it comes to welcome and introductions. I just want to report to the committee by way of welcome that our report is not yet on the department's website. The staff did a review just to make sure that there weren't any typos and things like that. And in discussions, there's a couple things that have been brought to my attention just for clarity. And so I'm going to make a couple edits based on that. I just want to report to you members the nature of the edit. There were a couple places where it seemed unclear whether we were recommending as a committee that DCS appropriate money. And that's kind of confusing because we're a statutory committee, we're reporting to the legislature, and we should make it clear when we make recommendations about the expenditure of public money, that what we're really doing is recommending that the legislature appropriate monies to DCS for that purpose. DCS doesn't have any authority to spend public money outside of the budget requests that they make and receive from the legislature. So I'm going to make that recommended edit in just a couple places for clarity, that in places where we're looking for new resources to the department, that's a request we're making of the legislature. So I'll be sending that around through Felix for everyone to see where those two places are, but I just wanted to give you a heads up about how that works. And once you've all had a chance to weigh back in with Felix, you've had a chance to look at it, then we can consider the report final and we'll get it posted on the department's website. Any questions, members, about that? Very good, thank you. All that by way of welcome and introduction. We're going to move on to the first substantive agenda item number 2. This is the update on evidence-based programs the department is looking to explore for prevention services. So we have a presenter for this agenda item. Is there anyone from the department that's going to present on agenda item number 2?
Yeah, Peter?
Yes.
Yeah, can you hear me? Yeah.
Yes, I can hear you.
Okay, so this is agenda item number 1 you're looking at?
Number 2, update on evidence-based programs.
Okay, that would be Heather Coles. Heather, are you able to speak? I know you were going in on the phone.
Okay, let me try this. I have Heather's presentation and I'm going to put it up there now.
She just emailed and said we can't hear her. But she can hear us, I believe.
Heather, you're going to need to call in on the phone number.
Why won't this work?
Felix, I'm going to send you this presentation.
I have it. It's up on screen right now.
Hello, Heather,
I think.
can you hear me?
Heather?
Yes,
Yes,
this is Heather.
we
Can
can
you
hear
hear
you.
me?
Okay.
Great. Sorry
Hi,
about
Heather.
that. Hi, good evening. Sorry about the technical difficulties.
No problem. Go ahead. We're eager for your presentation.
Okay, great. So I'm not seeing, I saw the slides up, but I'm now seeing the live event will continue in a moment. So I don't know if anyone else can see the slides.
Can everyone see this slide?
No, I'm seeing
Yes.
the same thing. The live event will continue in a moment. Is what my screen says.
Felix, the slides went away. If you have it, go ahead and share it to the live event.
We have it in our packet. Okay, if you have it in your packet, we will go ahead and get started, and I will try to then reference the slides that I am speaking to. So my name is Heather Coles. I'm a senior staff associate with Action for Child Protection. We are the agency who is overseeing the implementation of Family Connections. So I will be overviewing the Family Connections program very briefly for you this afternoon, as well as why it was selected. In addition to Family Connections, the Nurturing Parenting program was also selected. So I will talk just a little bit about how we will be looking to integrate the two programs together. With a caveat being I'm not with the Nurturing Parenting program, but I will try to convey that information as best as I can. So if you all could look at slide 2, which is the service array slide. This really briefly gives an overview of this really pretty radical service delivery change that the state of Arizona is looking to make for the benefit of the families served by DCS. And so in selecting the 2 programs that will be essentially taking over and substituting for several programs currently in place, Arizona really looked to find services that could be well adapted to individual families and delivered in a way that was culturally sensitive to each unique family. And one of the benefits of the Family Connections program, when I outline for you the different parts of it, will be that it first focuses with families to help them address crisis or emergency needs, helps elicit their understanding of the need for changes to help facilitate the change process later. And in implementing Family Connections and Nurturing Parenting program, DCS is looking to help have less disruption of services. Previously, when families moved from different case types, let's say the children were in home and were removed, or vice versa, children were out of home and ended up reunified, they would end up switching between services and between service providers. And so we are looking to really minimize that form of disruption. And with that, the programs that Family Connections and Nurturing Parenting will be replacing are Building Resilient Families, Intensive and Moderate In-Home, Family Reunification, and the Parent Aid Skill Building Sessions. So we will be looking to try to offer a more comprehensive array delivered by this program, by Nurturing Parenting, and then having the Family Connections consultant refer families out for formal treatment-based services when those are needed, and services that can, such as therapy, that will be able to stay with the family for longer time periods. In also considering this systemic change being undertaken, one thing that we are looking to do is to separate the safety assessment and planning process, which is really the expertise of the DCS specialist in terms of their assessment, their implementation, and their oversight of plans. And the Family Connections consultant will be the partner with DCS to help then ensure that the necessary services are in place for them to help them meet the bigger, longer term goals set forth on their DCS case plan. So the Family Connections program really looks to help families identify what needs to be enhanced in terms of either protective factors. Some of you may be familiar with the protective factors framework, which goes hand in hand with the safety model, SAFE-AZ, that's used by DCS. So helping to increase the protective factors that will help reduce risk of future maltreatment or subsequent referral to the department. For those cases in which children are unsafe and in-home or ongoing will be involved, the Family Connections consultant will be partnering to help the families enhance those protective capacities that need to be enhanced for the elimination of danger to the children. Family Connections will also be working with the families for whom kids are in out-of-home care to address what needs to change for children to be reunified with an in-home safety plan. And those are called the conditions for return or conditions for reunification. With this service array change, we are really looking to have a collaboration for training to build a community of practice with consistent language across the state. And then finally, in terms of how these 2 programs were chosen from initially a large number of programs, later approximately 30 or 35 were looked at more closely. Arizona DCS looked at which programs have an evidence-based. And what you will see, I will briefly show you a few slides that summarize a wealth of literature available about Family Connections in terms of outcomes found across the country for sites that have implemented. And if we move now to slide 3, I won't spend too much time here. We have a lot of material we have been writing and developing for Arizona on really the conceptual framework for how this program was developed. But briefly, prevention science, the developers of Family Connections looked at into the literature, into the research, into practice to find out what were the conditions that, or the factors, if reduced, would help reduce risk of maltreatment. And with that, what protective factors, if promoted, would also contribute to the reduction of maltreatment. In terms of intervention research, what we are looking to do with Family Connections is to be able to tailor interventions specific to what is needed in a particular family. So you will find that there isn't a one-size-fits-all plan developed with the family or array of treatment referrals. It really is a purposeful and individualized intervention system. With the intervention research, we also have integrated a number of different well-studied and well-documented social work principles and practices. And while we don't require the Family Connections consultant to be a licensed social worker, we afford them training in some of the principles, techniques, and skills that they can integrate into their work with families. Implementation science is used to help plan, implement, and then later measure fidelity to the practice model as it's brought into the state for the first time. And part of implementation science is also adjustment. So after a new intervention is implemented, using results pulled from things such as QA activities, adjusting to make sure that the intervention works for its population. And finally, part of why we are here today is to really value and to bring in provider communities and stakeholders to help support the implementation process. So slide 4 briefly highlights for you the history of the Family Connections program. You will see the first demonstration project was a 5-year project in 1996. It was much research was done at that point, and later replications occurred and were also researched in small and large rural and urban communities. And a number of studies were published from the results of those implementations, which led us to having the evidence support that we do today. Slide 5 briefly highlights for you the numerous different social work and psychological type theories that were drawn from in the development of the program. And as I mentioned earlier, are incorporated into training and support for staff who implement Family Connections. Slide 6 moves us into some of the philosophical principles that underlie this practice model. First, the ecological developmental framework helps us view child abuse and neglect and risk of maltreatment within a family system. And knowing that the family system is influenced by and interacts with each other, we look at how risk of maltreatment and child abuse and neglect operate across individual, familial, community, and macro levels. In terms of community outreach, a big focus of Family Connections consultants are making sure families are connected with what they need in their own communities, so that Family Connections can be as short-term of an intervention as possible. And so with that, they really help provide some advocacy, referral, and helping support families who may be disengaged or unconnected within their communities. We practice from an empowerment and a strength-based model. The value of the families having their own voice and having choices is interwoven throughout the entire program. And we believe that when empowered, families can come together with support to help develop solutions and solve problems that they're facing. And finally, cultural competency. Can't speak enough of how important this is. One of the large reasons and one of the objectives of implementing Family Connections in Arizona is to have a program that deliberately looks at an individualized family assessment, knowing that in Arizona and across our country, we have children and families of color who are disproportionately represented in the child welfare system. And so we deliberately look to have an assessment that seeks to understand the family's cultural background and their values, and deliver interventions and make referrals to treatment-based services that are culturally sensitive and appropriate. Moving to slide 7, we have a few more of the underlying philosophical principles. I just mentioned a bit about family assessment and tailored intervention. Our family assessment incorporates standardized computerized tools, which will help the Family Connections consultant narrow the focus with the family around where are areas of need to address risk or safety concerns. Also has been found to help make discussions easier. Asking a parent sensitive questions about parenting may be intimidating if there isn't a standardized tool. And so that has helped in some of the implementation sites. Part of the family assessment process, we are also looking to include some trauma tools. It's well known that many families in the child welfare system have had individual or familial trauma. They've also had trauma possibly from situations they've been exposed to within their communities. And so we are looking to integrate a trauma assessment for those families who are willing and interested in starting to explore how trauma has affected their family's functioning, and begin to work on strategies to adapt to it differently within their homes, and to receive referrals to treatment providers qualified to address their trauma needs. In terms of the Helping Alliance, goes right along with that engagement and empowerment I talked about earlier. We really stress the Family Connections consultant building a strong partnership with the family starting at the very first contact. They then develop a service plan, generally within 30 to 45 days of their first meeting, based on the results of that standardized assessment and from the other information they have learned about the family. The service plans are short term. They are about 90 days. And so what that does is really helps the family focus on what changes are realistic and feasible in that time frame. And for those families who will also be involved with DCS ongoing or in-home services, the service plan delivered by Family Connections will really help provide intermediary steps towards progress towards their larger objectives set forth with DCS around what behavior changes are needed long-term for their children to be safe and or have risk conditions reduced. And finally, our focus on the practitioner. We really focus on building the awareness, the self-awareness of the Family Connections consultant in terms of what are characteristics of the helpers and what do they bring into the relationship that can influence the level of engagement of the parents and the parents' interest and trust in working with them. We now move to slide 8. You see here a definition of what is Family Connections at its highest level. As I mentioned earlier, for those families who are ready and interested to consider trauma, the trauma adapted version of Family Connections adds on essentially just an additional layer of assessment instruments and some change focus interventions that are tailored to families who've experienced that trauma. And so in Arizona, the intake process will really be more of a referral process. The DCS specialist who has completed an assessment of the family understands if there's danger or if there's risk and what exactly those danger threats or risk factors are, will be then deciding if a referral to Family Connections may benefit the family. And we are working actively to finalize criteria around that now. Once the family's referred, we really stress timely service intervention. It's very much been my experience that as soon as families enter into the child welfare system, early on is really your biggest opportunity to engage families. They're usually pretty motivated to resolve whatever has brought them in or has led to the referral. So the outreach and the engagement process generally occurs within 1 business day by the Family Connections consultant, or they make diligent efforts to have contact within 1 day. There's then the first focus of what are the concrete or emergency needs of the family. It's really hard to work with individuals on higher level changes when basic needs aren't met. So for those of you who may be familiar with Maslow's hierarchy of needs, that's really a philosophy we bring into that first meeting, is to help the family identify and address and find solutions for any concrete or emergency needs they might have. The family assessment that's done by Family Connections, including the use of those standardized tools, generally occurs within the first 30 to 45 days. And as a result of that, within 2 weeks of the family assessment being done, we then develop the service plan with the SMART goals. After the service plan is developed, weekly contact, at least weekly contact, will be occurring with the family to have in-home change focus interventions. When it is identified that parenting practices or parenting attitudes are contributing to the risk or the safety concern, that is where a referral to the Nurturing Parenting Program will fit in. And then very briefly, the Nurturing Parenting Program is a well-established, well-researched program. It includes at least 30 different curriculums that can be implemented based on the family's ages, culture and language, and their learning style, to then target whichever level of parenting intervention they might need. And within Nurturing Parenting, they also use standardized tools that we will be using in Family Connections and have used in Family Connections as well. So there's going to be a natural progression of parents getting the Nurturing Parenting education, and then the Family Connections consultant being in the home with the family, helping support them in implementing and trying out the new things that they are learning as part of their Nurturing Parenting curriculum. And after the service plan is done, every 90 days, we have a formal evaluation of change. That does include re-administering the standardized tools, which is pretty exciting for families to be able to see side by side where things are changing and not just hearing the opinion of their consultant and what they've observed, but actually seeing on paper changes, hopefully towards the measures that they were focused on. And then the evaluation of change and continued change focused intervention can occur once, twice, 3 times if needed. Arizona is looking to cap participation at 12 months, which is, from our implementation at other sites, very, very reasonable. Most families, if they are have continuing needs beyond that, probably aren't making very good progress or are becoming overly dependent on the program. So there will be very clear evaluation every 3 months to determine if there's continued benefit of delivering Family Connections to the parents. And so moving to slide 9, Arizona's target population will be families with children under the age of 18 who've either been identified at risk of future maltreatment and or placement, so applying that protective factors framework, or children who are involved with DCS because they've been identified as unsafe with their parents or caregivers. And so Family Connections will be working with in-home cases as well as out-of-home cases. Slide 10 briefly shows you the outcomes that we have directly linked to specific protective factors and to specific protective capacities on unsafe cases. And so each of these outcomes will be the focus of the Family Connection Service Plan and later of the Change Focused Intervention. There are going to be standardized instruments tied to each of these core outcomes. And then moving to slide 11, very briefly, we have a summary of some of the research that has been done over the last 15 years or so since the Family Connections has been in existence and has been researched. We do see that Family Connections has resulted in caregivers who completed the program 6 months post-intervention to maintain reduction of risk factors, including parenting and life stress and depressive symptoms. We have seen an increase in protective factors, including social supports, parenting satisfaction, and parenting attitudes. Slide 13, we have found there's been improvement in the physical care of the children in their parents' home. An improvement in the psychological care of the children, including the caregiver teaching and stimulation of children and children's mental health needs being met. And also we have found that families that successfully complete Family Connections have fewer future reports and future substantiated or indicated reports as compared to those families that do not participate. Slide 14, we have found that children who are involved with Family Connections and presented with behavioral concerns as measured by the Child Behavior Checklist or CBCL measure had a reduction in their internalizing and externalizing behavior problems. And slide 15 briefly mentions some of the research that has been done. There's been replicated, at the time this research was done, had been replicated in eight different sites across the country. Those states are listed back on slide 4, but just want to reference that to you. And that there is a lot of literature out there if anyone is interested, including the citation on the bottom, in reading more about that program. And slide 16, again, just some of a summary of the outcomes. Referenced the CBCL earlier, and the decrease in parenting stress and depressive symptoms. Those acronyms are the tools used. The CESD is the Center for Epidemiological Studies Depression Scale, and the PSI is the Parenting Stress Inventory. Slide 17, again, just referencing that improvement in protective factors. The scales that have been used in the studies included the AAPI, Adult Adolescent Parenting Inventory, the Social Functioning Support, and the FFA, I believe is wrong. That should be the Family Functioning Style Scale, or FFSS. Apologize for the typo on that. And so finally, last few slides just highlight for you, as we are actively working with DCS, helping them in striving for the best implementation that they can have so that they can hopefully achieve the model with fidelity and achieve the results that they are looking to have. So we are actively working with prospective provider agencies who will be recruited by an RFP in the coming months. So we've been providing some information, having discussions with a number of different community partners around what this program will look like, what nurturing parenting program will look like, and what things they should think about in bidding for the RFP and also for considering what their staffing will look like. For fidelity, we really do stress routine supervision for Family Connections consultants to help them apply the model correctly, also help prepare them for their interactions with families, and to help them increase their self-awareness in terms of their use of self and what they bring into that professional relationship with families. I mentioned earlier length of service. So Family Connections will be offered potentially for up to 12 months, with each evaluation of change posing a point for approval of continuation based on the family's progress. We are actively developing a training plan with Arizona. We are looking to do a hybrid of e-learning modules that we've done in other sites, and followed by in-person training and classroom training, and then later some hands-on type of development training. And then fidelity. So that will entail having quality assurance staff able to review and monitor for the implementation of the practice. And then finally, on slide 19, to help support the implementation, we have been working with Arizona to help develop and to identify who in both the rural and the urban communities will be able to be part of this and to build and can be supported and trained to develop capacity to deliver family connections, and has combined your some national support. So our agency, Action for Child Protection, the Center for States, and the Family Development Resource Center for Nurturing Parenting Programs have all come together to help support the implementation team. And as a conclusion, on slide 20, you have my contact information as well as our Executive Director, Teresa Costello's information and our website. So feel free to reach out if you have any follow-up questions that aren't answered later on in this meeting.
Fantastic. Thank you, Heather. Appreciate the detailed presentation. Members, any questions for Heather Coles? I'm not hearing any other questions. Heather, is there I didn't see anything about time frames. Is there an implementation time frame that's public and being discussed in Arizona, or is that yet to be determined?
I believe we probably have Catherine on the phone who can speak a little more to time frames. We are looking for a go live date of July 2021, which sounds far away, but will come up soon enough.
Very good, thank you. Well, I appreciate it. In the interest of time, thank you for presenting to the committee. Thank you for your very informative presentation. In the interest of time, we're going to move to agenda item 3, which is the CMDP integration of behavioral health services from the Regional Behavioral Health Authority presentation. Who is going to speak to us?
That would be Carla. I still have pay quality. Carla, are you there?
Can you hear me now?
Yes, Carla, we can hear you.
We're having difficulties. I'm with Mark in his office, and if you're not able to hear me clearly, just let me know.
Very good. We can hear you right now.
Oh, we can't, yeah. So do we have the slides, or?
Felix, do you have those slides?
Yes, I will bring them up. Oh, no, I don't have slides from Carla.
Are you all able to see my screen?
Yes.
Okay, great.
No.
So I'm going to go right in and talk a little bit about the background for integration. I know most of you are probably familiar with this journey, but just want to touch base about how we came to where we are today. So as you remember, it was back in October 2015, there was a report released. It was the Senate Bill 1375 report. And it really investigated integrated service delivery design for children in care. And of course, that's evolved since that original report in Senate Bill 1375. One of the options contemplated in that report was that CMDP oversees and implements all aspects of that service delivery system. Subsequent to Senate Bill 1375, Mercer Consulting conducted a study of integrated service health plan for services for children in care. And in that 2018 report, there were multiple service delivery systems explored, ranging from fully integrated under CMDP to an administrative services organization, ASO model. And that's kind of some fancy lingo to say ASO would just manage the operational side of the organization. So really looking at claims, some encounters, which are basically bean counts to access, saying that there's service utilization, and managing the provider network. And in this model, a CMDP would retain the clinical operations. So fast forward, DCS released an RFP, and it was based on some changes also that were in ARS 8512, which is CMDP statute that allowed for CMDP to integrate behavioral health services and cover those, as well as removing some procurement restraints that tethered us to the access fee for service schedule. So not only can we move to a contracted network, but still provide an array of network. We had the authority to move forward and take over behavioral health service delivery for children in care. So with that, we released an RFP based on this ASO model option, and then it was in the summer of 2019. And it was determined based on potential bidder feedback that the financial model conceived in the ASO structure did not offer enough incentive for a partnership. Typically, health plans are used to being full risk, and in this RFP, we oriented the RFP more in a DCS-like structure, and health plans were familiar with a full risk structure. So as such, DCS ended the RFP process and we moved to a direct contract mechanism. And this mechanism really provided a partnership-based platform that really helped us solidify the final design. So in the final design configuration, of course, access contracts with CMDP for physical, dental, and now behavioral health services. And then DCS contracts a statewide managed care organization, which is Mercy Care, to contract with healthcare providers delivering the services on behalf of CMDP. Of course, CMDP retains full responsibility as the health plan for children in care. And so we have a real good focus then on the system of care delivery, and some areas of practice that have presented some challenges for children in care, and how can we enhance some of the system of care elements that we're already working on. So we can move on. So there's the big go live date of 4/1/2021, and not that we're counting, but I think we're at about 237 days. So we've got our work cut out for us. So let's just talk a little bit about the roles and the responsibilities now that we have a direct contract in place with Mercy Care. And I can reference, if you want to look at hundreds of pages, if you haven't done so already, you can find the best and final offer on their AZ procurement portal, and I've listed out where you should go for that. It also includes other offers that were submitted to DCS CMDP, not just Mercy Cares. It's part of a regular procurement process, so you're able to view those as well. So Mercy Care was ready to start rolling, and as we both had project plans where we've come together and melded our project plans. And the project plans include a whole host of areas. Obviously, as you can read here, communications is going to be one of the top ones that we start working on immediately, and some outreach. We need provider and community engagement, sharing what we do know, and doing meetings such as this, and sharing what we have done to date. Of course, network is very important, especially when we're looking at our specialized population. Grievance and appeals, clinical, which includes medical management, utilization management, looking at quality management, of course, and pharmacy operations, IT, and among others, including, of course, finance. So just a step back, let's take a look at a couple of these areas. For utilization management, everybody knows that the REBAs have the approval authority for behavioral health services requiring prior authorizations. And in the event of a denial of prior authorization, the DCS specialist may appeal the decision to the REBA. So when we think about just that circumstance, that scenario, future state, our CMOs and our Chief Medical Officer here at CMDP, and we've also acquired Dr. Sala Webb. She's our Behavioral Health Chief Medical Officer. And we're going to work with Mercy Care to agree on the clinical guidelines for authorization of services. So CMDP is going to delegate that approval authority, however, very different than in a typical health plan scenario. For any denied prior authorizations where we've agreed upon which services we want to see, we being CMDP, CMDP will conduct a secondary review and make the final decision on an authorization. So that's very different scenario than you would typically see. In terms of service coordination, you'll notice in the best and final offer, if you haven't seen it already, that we're looking toward a integrated rapid response. So not only having the typical rapid response that we have now, but adding a physical health component. And so we're working on what that model could look like, and we'll be asking for further engagement and feedback on that. And then around program design, network development, and maintenance, obviously, again, the REBAs are operating their network, and CMDP is operating our fee-for-service network. We call it a network, but really it's a very open, any access registered provider typically has been what we've done in the past. We do have a network of credentialed providers for physical health. So there'll be some very specific contracting and service delivery enhancements planned. We've talked about them at great length already, in targeting various subpopulations. Transition aged youth is one that we've highlighted, that birth to 5 population. So these are really kind of child welfare specific populations that we're looking at here. And then how do we engage Mercy Care, our partner in the service delivery and setting up any providers around that. Quality management, Mercy Care will have the standard health plan quality management, but that'll also include oversight by CMDP, looking at our performance measures. Our performance measures, our clinical performance measures are very high, and they exceed not only the Medicaid minimum performance measure, but we exceed most health plans, Medicaid health plans, anywhere from a few percentage points to up to 25%. So we have some high performance measures that we do not want to have any slippage on. So we at CMDP are going to put an extra effort into making sure that not only do we maintain what we have now, but we enhance that. In the future state, of course, Mercy Care will be paying both physical and behavioral health claims on behalf of CMDP, and they will be the ones credentialing the BHN physical providers on behalf of CMDP as well. So we've had numerous meetings already. We kind of had a kickoff meeting probably 3 weeks ago, and we've been moving on the various areas that are outlined here in the project plan. We have work sessions going, and then those groups will engage community partners and stakeholders along the way. So with that, and just quickly, no integration plan is complete without a name change. CMDP limited us to medical and dental programs, so we're just going to expand that to say DCS Comprehensive Health Plan. So we can, and again, we will be the regulator over Mercy Care, but serve as a partner to develop the provider network to meet the needs of our special population, and some other partnership innovative ideas that we're coming up with, and really tap into the technology that they have for engaging members and healthcare providers as well.
Thank you. Members, any questions about the presentation on CMDP integration? It was a strong presentation. That's why it's so quiet. We satisfied all of our questions right up front. Any last call for questions about this presentation? The next agenda item also is a DCS presentation. Felix, who will present on the Missing Children Initiative report requirements?
What'd you say, Peter? The next presentation is Mark's, and Armando, you have that presentation?
Yes, I have that presentation. Mark, are you able to share your screen? It might be easier if you can. If not, I can quickly just pull it up.
I should be sharing it, but I don't see it up there. But
oh, I could see it.
It's up.
Okay.
Yeah. Note that anyone who's watching the live stream, there's about a 3 to 5 second delay, so that's why you guys may not see it just yet, but it should pop up.
Can everybody see it, or is there anybody who can't see it yet?
Yes, it's up.
Yes.
Okay. So my name is Mark Avey. I'm a project manager here at the Department of Child Safety. One of my responsibilities is overseeing the compilation and publication of some of our more major reports. Several of those reports report on runaway youth and missing children. And so I've been asked to speak today a little bit about the data, as well as some quality improvement efforts that we have to address kids who are on runaway, not just the data, but compliance with some of our policies, and are we taking necessary steps to try to locate these youth and get them back into care. So I'll just start with a little data. This is a slide showing runaway youth for the past, about 15 months from last April. And this is broken out by length of time they've been on runaway status. So if you will look at the bar on the far right, which would be our current data, the most current data we have for August, you'll see that 42 of those kids have been on runaway for less than a month. The majority have been on runaway from 1 month up to 6 months. About 42 have been on runaway status for 7 to 12 months. And then the remainder, we've got 16 that have been between 1 and 2 years. And then the remainder, which is a very small number, have been on runaway status more than 2 years. We had been seeing a pretty steady decrease leading up until October of 19, and then we saw an uptick in the number of kids on runaway status since that time. And currently, our latest monthly report shows for kids 0 to 17, there are 233 youth on runaway status as late as June 30th. The next slide. These are children who are considered missing. These are children who have not run away but are missing. I'm putting together a little chart that shows how many kids have gone missing status since last July. So for the past fiscal year, we've seen a steady decline in the number of children who show as missing children. Obviously, these children are of great concern to the department. We would like to find them and have them return to care or return to care. Some of them never, they may go missing during the investigation process when a parent leaves or disappears before we are able to pick up the child, which the children may be in our legal custody, but we don't have them in our physical custody. So in an effort to try to improve the work we're doing with these kids, there have been some significant quality improvement efforts made by the department. Just a very high-level overview, they have initiated monthly case reviews. They have dedicated efforts to locate these youth by utilizing a variety of resources, which I'll talk about later, and then providing additional locate resources for staff who have children who are on runaway status. So the monthly case reviews, every week we provide updated data, and the program specialists who are a unique role. Most offices in, say, Maricopa, Pima, Pinal, possibly Yuma. Most offices that are larger offices have a designated program specialist. This person has a lot of different special projects. They may help with case reviews, they may help with data, they may do a variety of things, help provide some support to the program manager for that office. Some areas in rural areas may utilize one program specialist for multiple offices. So generally speaking, and again, it's very general, these offices are looking at each month anywhere from 10 to 20 kids that they're reviewing who are on runaway status or are considered missing. So what are they doing with these kids in their office when they're reviewing these cases? So the first thing they're looking to do are some of the key points in our policy that are required. Are those things happening in the case? So they're checking to see, first of all, the first thing they do is check to see, is the data that's in child accurate? First question usually is that child actually still on runaway status? Sometimes it just may be that the data has not been updated and needs to be done so. Then they're looking to see whether there are motion for pickups. Has the DCS specialist filed a motion for pickup? Have we filed a police report? Have we notified law enforcement that the child's on runaway status? Have we tried to make family contact? Have we notified the family that the youth is on runaway? Determined maybe the child has run back to mom's house or to a relative that they have a connection with. We're checking to see whether the specialist has made contact with the previous provider. Maybe the child has reached out to the previous foster parent or staff at a previous group home. And so it's going back to that previous provider to see if there's any information they may have to help assist us with locating the child. Have we notified the parents that the child is on runaway status? We can submit a school locate referral, reach out to their school and see if there's any assistance the school can provide or any information the school can provide to help us locate the youth. Then it's making a referral to the National Center for Missing and Exploited Children. That's required for all kids who are on runaway status or who are missing. And then we have what's called at-risk referrals, and I'll talk a little bit more about those in detail. So as a program specialist are reviewing these cases, they're working with the specialist and the specialist supervisor to provide a little support and guidance on the things that have or have not been accomplished, working with those specialists to get some of those tasks accomplished and seeing what supports the specialist needs to help bolster those activities. In addition, we have a dedicated staff member who is taking additional action to support the specialist to locate these children. So not just a specialist and their supervisor, but a staff person who is kind of making extra efforts. They're reaching out and contacting relatives. Maybe there's an aunt or an uncle. Maybe there's a significant person in that child's life who they had a previous history with, who the child may have reached out to or attempted to contact. Utilizing advanced search engines that we have available to us, for example, LexisNexis, and utilizing some of these tools, a little bit more advanced tools than just simple Google, to help see if there's any information in social media or other venues where we might be able to get some information to help us. Contacting known supports of the youth. So is there maybe a former soccer coach or a former teacher or church member or somebody in the neighborhood who the child might have a special connection with, who may have had contact with the child, or who may know something about the child that would help us in our search. And then they provide the specialist and the supervisor with this expanded list of additional relatives and support, so that specialist has that moving forward. And then this person will also either visit some of these relatives, visit these known support. They may send them a certified letter, or try to reach out and contact them directly, speak to them and see if there's any information that they've got. And I talked a little bit about these program specialists in each office now have access to LexisNexis to help. This is a much more advanced search engine that can look at a variety of databases that most of us would not have access to. We created an inbox with our Office of Child Welfare Investigations for what we're calling at-risk referrals. So there are youth who may be at, a worker may decide that they are at higher risk while on runaway status, and OCWI can also utilize some of the resources they have with law enforcement and some of the skills that they have in their unique capacity to provide additional and more intensive efforts to locate the youth. We've also got a family locate unit, which we utilize for a variety of purposes, but they can also provide some extra support, doing more intensive searches to take a little weight off the specialist's shoulders and to provide some additional support to get more information that might be possible. And obviously we would be looking to see if there's any information on National Center for Missing and Exploited Children in that website. So the at-risk referrals. So if a worker believes there is no standard that, in no boxes that have to be checked to say what makes a youth an at-risk youth to send a referral to OCWI to get assistance. They won't, OCWI will not deny a referral that's made, but typically these kiddos may have been on an extended runaway episode. Maybe they've been on runaway for more than a year. They may have serious behavioral health history, a history of suicidal or homicidal ideation. Maybe their substance abuse history is quite chronic and quite extensive. They may have risky sexual behaviors or history that would put them at additional risk if on runaway status. So these kids can be referred to OCWI, and they have staff who will assist the specialist in utilizing some of the tools they have available to them. And so when they're reviewing, when the program specialist is reviewing the cases, they're asking a series of questions. So they're reviewing the data. One, is the child a crossover youth? Are they dually involved? That's usually a good place to start. Make sure we're talking to probation officers and others involved in other systems the child is involved with. Have we verified that the data is actually accurate? Like I said earlier, we want to make sure the child is actually still on runaway status and the worker has updated that information. If a youth has returned and the worker has not indated that runaway in the system, then it might still be showing up as a data element. In addition, separate and apart from what the specialists are doing, each time we issue the semi-annual report, we do some intensive data cleanup, really a manual data cleanup, where our data folks are sending me a list of all the kids who are on runaway status and those children who have exited by reason of runaway. And then we're going in and actually looking in that case to, first of all, we want to look at any kids who are under the age of 12, particularly if they're showing as a runaway, to make sure that the worker has entered that information accurately. We also want to make sure that the kids who are exiting by reason of runaway, sometimes the system right now, the child system allows for the potential for some error if you select reunification as an exit reason, or if the child's on runaway when they reach the age of majority, they may be selecting the wrong exit reason, and we do a review of the case to make sure that the correct exit reason was selected. We're looking at the data, making sure that a motion for pickup has been filed, that the police report has been made, and that monthly locate efforts by the specialist are being documented in the child's database system. Making sure that we have notified the parents that the child is on runaway status, and letting them know what action is required of them and what they can do to support having that kid return to custody. Was a school locate referral completed, and have we reported that child to the National Center for Missing and Exploited Children? And again, making sure that not only specialists are aware of the at-risk referral that can be made to OCWI, but making sure they have at least made that determination to submit that referral. And if one has been submitted, what's the status, and do we need to resubmit it or provide them some more information to assist them? And that is pretty much all of my presentation. Obviously, open to any questions you guys may have.
Thank you, Mark. I appreciate that informative presentation. But in terms of metrics, I'll ask the first question. What is the best metric to look at when we're going to be thinking about improvement and success rates? How do you all think about following the data and knowing when trends are moving in the right direction or the wrong direction?
Well, I think one of the first is making sure that the data is accurate within the system. And what we're doing with the semi-annual, as well as what they're doing at the front end of these case reviews, is probably one of the most important pieces. When we really started tackling this problem about 2 years ago, we were noticing children who were 2 years old and being called runaway. And we questioned, is a 2-year-old really run away from home in terms of the way we normally think of a child who's on runaway? And the system allows you to make one of two choices. You can select runaway or missing child. It's what we call a manual placement. And the system also does not force a worker to indate that manual placement episode. So if the child does return and they create a placement with a licensed foster parent, for example, the system doesn't force them to indate that runaway. And so we want to make sure that that runaway episode was indated, because it will still populate when we're doing aggregate data counts. So there was just a lot of data cleanup that we have focused on that I think has been critical. And then I think as we continue these case review process, to make sure that the critical pieces of what they're trying to measure with this monthly case reviews is the next page. You know, are we making, has the youth been reported to NCMEC? have we filed a motion for pickup? Has a police report been made? I mean, those are critical pieces to making sure those things have been done, as well as, and I don't know how you put this in data, but definitely it's utilizing those locate referrals and our folks continually making effort at utilizing the locate tools that we have available to us, that's being done on a regular basis.
Do you have the ability to track the average length of being on runaway status or missing status?
We do. And this slide that I'm showing now, I guess I just realized I'm showing you my whole screen, not just. Can you still see my screen?
No, Mark, it went away.
Okay. Give me 1 second.
I can still see it.
Okay. So, excuse me. So on this chart, this shows the number of children on runaway combined, and then it breaks it out by the length of time they've been on runaway status. The majority of which really fall in that 1 to 6 month time frame. Now we can't automatically say, so for example, if you look at July and August, we can't say if these 3 kids that had been on runaway for a month, did they roll over into the next category of 137 on 3 to 6 months? Some of those kids may return, some kids may return and then they run away again. So, but we can generally show how long kids have been on runaway status by this, using these date ranges.
Do you have a set group of criteria for when a child is no longer on runaway status or no longer on missing status for what the outcome is, whether it's return to department custody or perhaps return to family or something like that? What are the categories that those fall into?
So if they're return, I'm not sure I understand what you're asking. Category for when they return from runaway status?
Yes, they're no longer appropriately classified as missing or runaway. What are the possible categories for them?
Well, it would depend on where they're placed. Because this is considered it's not really a placement, but when we're wanting to say where is the child located, what is the out-of-home care provider, that would, if they go to a group home, they would fall in the group home count. Is that what you're asking?
Yes, I think so. So they basically would just receive the same kind of placement at that point. They're located, they're still within the custody of the department. So they'd have the same kind of placement codes or placement categories as any other child in custody of that point.
Right. Once they're located, the trigger would be that obviously when either the specialist locates them, they will have to submit a service authorization for their new placement, which would trigger removing them from the runaway category and having them in, say, a licensed foster home or a group home, whatever that may be. And that's if it's, say, for example, law enforcement picks them up and maybe law enforcement calls the hotline. Obviously, it's still that contact between law enforcement and the agency that notifies the worker that the child needs to be picked up and the placement process begins.
Okay, makes sense. Thank you. Members, any other questions for Mark?
Peter, this is Sergeant Laws. I've got a couple of things.
Please
Sure.
go ahead. Thanks.
So for law enforcement, and I can speak for Mesa Police specifically and in general for law enforcement, but for these kids that run away, we have to remember that these are kids that are voluntarily running away on their own and that they're actively trying to evade being found and being located. which is typical for anybody who runs away. It's not just for DCS kids, but that's just who we're dealing with first off. The first issue that law enforcement runs into that is a frustration for us is when we show up at a group home or even a foster home, the training for those that are in charge basically is if the child that walks away, leaves, or even threatens to leave, that they cannot physically stop that from occurring. In fact, they'll call us and say they're walking away, I can still see them, but I'm not stopping them. And so our frustration is, especially when we have multiple runaways, the same repeats over and over again, is we know that they're runaways, we know they're going to run away, but there's no, it is difficult for law enforcement because there is no upfront measures put in place to stop the child from running away again. Is there something that you guys are doing to address that?
So that starts to fall out of my wheelhouse, so to speak. I know that a group home staff, for example, they can't tackle the child. They can't forcibly block the door, block them in the house, but they can call crisis response if that seems to be the issue. Sometimes it may be the child and the group home staff are having a conflict, or maybe another child is having a conflict, or they're really struggling with the transition into foster care. So the group homes and placements and grandparents and foster parents, when the child is placed, they're given information for the crisis response unit and the behavioral health team and who their members of their child and family team may be, so they can have a crisis plan in place to help de-escalate that situation, so they don't completely leave and run away. But obviously there's where staff and placements cannot physically bar that child from being in the from leaving the house. They can't tackle them, or they can obviously lock doors as needed as they would throughout the normal course of just securing safety for all the children in the home, but they can't do anything to restrain that child unless they're a danger to themselves. And I think there's even limitations on how that would be.
Yeah, that's my understanding as well. And I understand what you're saying. I'm making sure that the committee is aware that when we're talking about how the child goes missing, very few children go to their case manager or the group home worker and say, I'm going to run away. Most of them just run away without any knowledge, or they'll say they're going to their room. I mean, like any other child that is upset, they don't typically say, I'm going to do this. They just do it, and then we find out they're missing after the fact. That's one piece of the frustration. Law enforcement does most of the things that you've enumerated as far as how to find a child after they're gone. But second to that is when law enforcement gets notified about a child that's gone missing, we have a certain protocol that we do initially in that very first few minutes to try to do what we can to saturate the area and try to find the child. A frustration again that law enforcement has is that there's directive from DCS that we are not allowed to put out media releases or even bulletins to the community to let them know, which is standard practice for us. If any child goes missing, we'll saturate the area with social media, with bulletins that we'll put in convenience stores or things like that, so that we can have the community be our eyes and ears looking for that child. We're banned from doing that when it comes to DCS kids. Is there any thought on that?
Yeah. And I would have to defer to somebody else on the whys and the wherefores of why we can't do that. I'm assuming that confidentiality plays into that a large piece. I know one of the key pieces is for kids who have multiple runaway episodes. Obviously, if it's a child's first episode, that's a much different situation. But one of the things that's just a continuous effort is if children are running away, if a youth is running away, then the child and family team really should be looking at what's driving that behavior, what needs to be put in place to help prevent a future removal, or I'm sorry, a future runaway episode. Is it that the child just has a substance use problem and they're, leaving because they want to go party with their friends that weekend, versus is this a child who's running away to stay away forever? And trying to go somewhere where he can hide and avoid authority. So that child and family team really should be looking closely when a child returns from a runaway episode, is the placement equipped to handle these episodes, to kind of maybe see, are there any red flags or triggers that we can identify that might tell us that the kid's bordering on a runaway episode. So that's definitely an ongoing challenge and ongoing need for just continual conversation.
Right. And one last point I wanted to make is, this is personal experience. So myself, I am over our special victims unit, which typically is sex crimes, but we also take care of all of our missing kids that initially get called in. And so I get these calls all the time. And I can tell you that me specifically, we get phone calls from the same group home for the same kids over and over again, multiple times throughout the same week. They go missing for a day, two, whatever, they find them, and then they just go missing again. And so a lot of this is just repeat. And we have conversations with the group home saying, what can we do to fix this? And we get put into the workaround of talk to their case manager, and we just get in the run around of how we're trying to help that happen, so that we can get the kids in a better place where they wouldn't be causing us to have putting those resources in for them over and over again. And again, this is probably not up in your alley necessarily, but I'm just making sure the committee is aware that there are a lot of other factors that are in the front end of the stats that you're putting up here.
Well, and I would say along those lines, when I talked to the director about presenting, he did want me to make sure that everybody understood we would invite and welcome any recommendations or suggestions you have. One of the things we started to do, and the data's a little wonky, so we're still trying to see how we actually do that with the data we have available to us, which was to look at, are we seeing group homes who are having kids with a lot more runaway episodes than others, you know, and what that might look like, because we might expect certain types of group homes to have a higher incidence of runaway because of the nature of the behaviors of the kids that they take if they have they're a structured or unique group home. But we're definitely trying to find ways where we can look at that that particular issue that's a little more data driven, and then if we are able to look at which homes, and the next step is obviously what's driving those numbers, and I think that's where we'll really need some support from the community. What suggestions are out there and what recommendations you guys might have, that how would you address those issues? You know, how would you really kind of tackle working with those group homes that have those high incidents of runaway episodes, and how are they responding when the kids come back, if they let the kid back?
I can tell you, right, I can tell you from our experience that the group home people we directly deal with are frustrated because they feel like when they call case managers for the kids, they're basically told they're going to come back and it's going to happen again, but it is what it is. They're not getting the support of, we're going to find a different location, we're going to split kids up. We have, for instance, recently we've had a group of kids that have run away together multiple times, and they have not separated them. They keep sending them back to the same group home, and the three of them together are, you know, they're going to keep doing it, and they say they're going to keep doing it. So our frustration is that we have a need for them to be separated, because that would limit their going out like that, and we feel like we're not getting that response.
Do you see similar things with foster homes, or is that not really something you guys notice?
Yeah, foster homes have the same thing. They'll call us and say that the child's run away, probably not to the same degree because they have less rotation in a foster home than a group home, but they will call and say, you know, we got this placement ran away. We've called the case manager, and the case manager said when they get returned, they're just going to stay here. Even if it's repeat, they get told you're going to have to deal with it. And that was my experience as a foster parent myself. For the years that I was a foster parent, we had the same experience.
And is there anybody within the department other than the specialists that folks are talking to or communicating with? Is there any conversation with placement or placement administration?
Well, we have had my investigators call the case managers for these kids, and then try to go up to their chain to bosses and things like that. Very rarely do we get a response of, we're going to make a change. Mostly we get told this is where they're placed, they're going to stay there unless they become a danger to themselves or others.
Okay. And I kind of was curious when you had talked about you're not able to utilize some of the same resources, you know, social media, different things. Are there specific things that you guys would use if you could? I mean, I'm just trying to identify what you guys use. Is there any conversation that can be happen that would allow us to use you guys to be able to use those resources? I mean, obviously, I think there's some things that are just, we can't allow confidential information out to the general public, but are there some things that, you know, may be more restricted is there any wiggle room, I guess is what I'm curious about.
And I don't see that wiggle room. And when you're looking for a specific child and you're giving their name, their date of birth, what they look like, what they were last wearing, you can't edit that out of a bulletin. So that's how we would normally look for a child. We can't just put a blind bulletin out saying look for a 12-year-old. You know, so I understand that there is a reason for the concern for the confidentiality. But if they're a missing child, they're a missing child. If they're a runaway, we would react the same no matter what. We're going to try to find the child, but our hands are tied because we don't have access to reaching out to the community like we normally would in other circumstances.
Okay. So I'm just writing these ideas down to.
Thank you, Sergeant. This is a good discussion. Any other questions? Any other feedback?
I do have a question. This is Dr. Conklin talking. Can you all hear me all right?
Yes.
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 Okay. I'm just wondering, when they do come back from runaway status, is there a screening process where they're checked for, you know, their urine's checked for substance use, they're assessed for sexually transmitted infections, they're provided with those types of services and health services, or do they, you know, go straight back into the group home and we don't necessarily do a health assessment afterwards?
So, and this gets a little outside my wheelhouse, but I know if a child's been on runaway status for 2 years, obviously one of the first things the worker's going to want to do is have that kiddo get in to see the doctor, because obviously they probably have not had a well child or another dental or medical exam that they're more likely overdue for. So obviously, if a kiddo's been on runaway for that long, if they've only been gone for, say, the weekend, because the foster parents didn't know you can't go hang out with your friends all weekend, and they decide they're going to run away so they can do that, and they come back on Monday. You know, I mean, I don't think unless a worker has a good reason, it's not a standard that they would do a drug screen for a youth. Now, if they have concerns after the kid comes back and they feel that, you know, then there's a referral through the behavioral health system to get some services for substance use. Those kind of things would be determined through that process.
I see. I mean, the reason I think of it is if we aren't picking up the people who actually have a substance abuse problem, or maybe they've run away, or, you know, there's some sort of underlying manipulation or trafficking that's going on of the individual teen too, I think that there should be some recourse for a health assessment after that runaway status and maybe a timeline. But it only takes, you know, 12 hours to get up to some really good trouble. So I think that there should be some sort of follow-up in that respect, so that if there are services that need to be provided, they can be provided in a timely manner.
Okay. Well, and when kids do return, one of the requirements related to sex trafficking is they should be having a conversation if there are indications that they've been sex trafficking. There are some additional steps that they need to take, and obviously the concern would be, you know, does a medical or some type of exam need to be made that because of possible sex trafficking or sexual activity, even if it's not sex trafficking.
Right, but I really appreciate the work that you do. So thank you for doing the work you do.
Sure, thank you.
And this is Sergeant Laws, just on that last note. We do on a regular basis get, when these missing kids come back into care and they make disclosures about having any sexual activity, they do come to our center and we are able to take care of them just like they would at Child Help. We offer them exams and do the interviews.
Any other questions, members?
And obviously, if you guys think of other things that are critical that need to be, that the department can focus on or consider for some future planning regarding these kiddos, like looking at medical, UA, other exams that may be needed, kind of addressing the issue of when the children are coming back, the responses you're getting from workers, those types of suggestions, feel free to reach out to Felix and he can pass those along to us.
Thank you, Mark. Thank you, members, for that discussion. We're going to move on to the call for public comment. We're not going to have an active real-time call for public comment, but if any members of the public would like to communicate with the committee, our email address is community-advisory-committee, spelled out as one word, community-advisory-committee@azdcs.gov, and community-advisory-committee@azdcs.gov, or if you Google DCS Community Advisory Committee, you can find a way to connect with us there and send your questions in or comments to the committee, and we will review those. Members, what's remaining is to set our agenda for the next meeting and to just overview our schedule for the remainder of the fiscal year. The next meeting is October 2nd. And at this point in time, we're probably at a place where we have to assume that we're going to meet virtually or digitally like we are now. Does anyone have any requests or points of focus for setting the meeting for that October 2nd?
Is this for the committee to offer up suggestions?
Yes.
I do have a couple of questions. You know, we are in a pandemic after all. And I'm sort of wondering how this pandemic is affecting placement of youth, of kids in general, either in foster care settings or into group homes. If there have been delays in that, if there are certain types of systems and protocols that the department has put in place to help if some placements are being disrupted, or other kind of testing of kids, and just kind of what's occurring around the pandemic in general for kids in care.
Okay, that's a great topic. So is the best overview of it placement trends in light of COVID and the experience so far in terms of specific placements and how that's changed because of COVID?
Right, and even, you know, the distance learning. I mean, there's so many ripple effects from this. Just if placements have really been affected, or education, you know, what are kind of the consequences that, or some of the major trends that are coming out of the department, and then just some statistics perhaps on themselves as far as how many are being tested positive, how many staff are testing positive, what are some of the precautions in the pandemic plan that the Department of Child Safety has put in place.
Okay, excellent, very good. Is this on Saria?
Yes.
Okay, thank you for that. I think that's a great agenda item for the next meeting.
Thank you.
So we'll make a note of that and make sure that gets addressed. Members, any other requests or any other topics for the next meeting? Felix sent around the DCS strategic plan that's recently been adopted, and in prior years we've gone over that plan with usually someone in leadership at DCS, sometimes the director or sometimes the deputy will go over that with us. But maybe that would be a good topic for us to, now that we have a new plan that's underway. How do you all feel about that? Any reaction to that? Is that worth the time for us as a committee, or would you prefer to just read the plan and we can put it on later if we have specific questions? All right, I can get with Felix to put other things on, possibly any other agenda ideas. One of the reasons why we make this an agenda item is because it's hard for us to connect together personally because of the open meeting law. So this is the one time when we have a chance when we're all on the phone to be able to throw out ideas for the agenda. It doesn't mean we can't craft the agenda. It just means we can't together craft the agenda. So that's why we throw this out.
Peter, if anyone has an agenda item, they can send it to me, and then I can forward to the rest of the committee for their opinion, I guess. I could check with council to see if that would be okay, but they can send an agenda item to me. Would that be acceptable?
Okay. Yep, that's fine, and at the very least, you might not be able to forward it to everybody, but you might be able to just forward it to me as the chairman, and we could discuss other items of the agenda. All right, the meeting schedule is there. Agenda item 7. October 2nd is our next meeting. Then we have December 4th, February 5th, April 2nd, and June 7th. We don't have anything slated to discuss in executive session today. I don't believe we have council on the phone anyway. So I think we're at the end of our agenda. Anything
Peter,
missing? Go ahead, Felix.
Also, I will send out Carla's presentation after the call, so everyone will have that as well. And obviously, it'll be posted online.
Thank you. I appreciate that. Well, thank you to all of our presenters today, to Mark, to Carla, to Heather. They were all exceptional presentations. It was very helpful, very informative, and I appreciate also the discussion that we had as well. Anything else, members, before we adjourn? If not, I'll entertain a motion to adjourn.
I got nothing else.
I second the motion.
All right. All in favor of adjourning this meeting of the DCS Community Advisory Committee, signify by saying aye.
Aye.
I think I heard at least one aye out there. Nays? Any nays or
Aye.
any other comments? Thank you. All right. In the opinion of the chair, that the ayes have it. Thanks, everybody. Have a great evening, and thank you for your time this afternoon.